What tests show if my myeloma is responding to treatment?
What kind of testing should we do for patients as they go through their treatment? Routinely, we will do peripheral blood testing, and that would include the testing for an M spike or the monoclonal protein. Often we will do also determination of the immunoglobulin, so the IgG, the IgA, and we will measure also routinely the serum free light chain. Now, in the older days, everyone also had a routine measurement of the urine, and there is still some debate about this, and some centers and your doctors may want to do urine collections. But in our particular center, and in my practice in particular, I have moved away from collecting urines on a routine basis to monitor for response. So we do it mostly through blood testing. Now, we help ourselves through deeper testing in situations where we have questions about the accuracy of those markers, or we may have a concern, for instance, of progressive disease. So in those circumstances, we may add imaging. For instance, we sometimes will do things such as a PET scan or a whole body CT scan. And also with some situations, we might do a bone marrow examination to look at what's going on with the myeloma cells in the bone marrow in greater depth. Obviously, this is a more involved test, so it's not something we do on a regular basis. In fact, there's not even a predetermined schedule when you have to do bone marrows, but you do them more at times when there is a need for that additional information as you decide on what the next step should be.
How frequently is testing done?
The frequency at which we perform tests depends on how the patient is doing and how aggressive the myeloma appears to be. The standard way of testing in general would be once a month. So once a month, we would repeat the free light chains, the M spike, and the quantitative immunoglobulins. In addition to that, we like to measure what we call a complete blood count, or the CBC, so we can monitor the hemoglobin for anemia, platelets, and white count, as well as what we call the complete chemistry, which includes a measurement of your kidney function, as well as the calcium. So that's what we do on a routine basis. Now, there are some circumstances where we may change this schedule. So for instance, if I have someone who has very aggressive myeloma, or if I have someone who has newly diagnosed renal failure because they have multiple myeloma, I might do the free light chains with greater frequency. Sometimes even once a week, sometimes even more than that, when I need to get a very early signal that what I am doing is taking me in the right direction, because it's very important. Otherwise, we may need to change treatment. So, a classic example for this would be a hospitalized patient with new onset renal failure. Now, on the counter side, if we have a patient who is on maintenance therapy, say with single agent lenalidomide, the patient is in low doses, has been doing well, and has been 2 years on maintenance, I think they don't really need to be tested monthly. So we will sometimes go as far as 3 months out between our tests. And of course, patients can always call and should call their clinical team if there's something that worries them or concerns them, and we can always do more testing in between. But usually every 3 months is sufficient.
So what tests are used to assess response to myeloma treatment? So we are usually able to follow tests in both the blood and urine to determine if patients are responding to therapy. The vast majority of myeloma patients have an abnormal protein called a monoclonal protein, or M protein, that can be found in their blood or in their urine at the time of diagnosis. And that M protein is a marker of their disease and allows us to follow it on a regular basis, say every few weeks, to determine if they're responding to the treatment. And so when a patient's getting a therapy regimen, typically at the beginning of every cycle of treatment, we'll repeat those myeloma tests. And if we see that the abnormal M protein is going down, then we know they're responding. If the protein is not going down or is going up, then we know that they may not be responding anymore, and we may have to switch treatments. There are some patients who don't make a high enough level of M protein to measure in the blood or urine, and in those patients, we can follow them either by doing repeated bone marrow biopsies and trying to actually count the number of myeloma cells in the marrow, or we may use imaging tests, such as a PET CT scan or an MRI, to see if their myeloma is responding to treatment. So all of these can be used in the response assessments for a patient.
When we treat patients with multiple myeloma, we typically follow some marker of the disease in the blood or in the urine to help us understand how the disease is responding to therapy. For most patients, that's an M spike, which is a monoclonal immunoglobulin in the blood, or that's usually an IgG, or less commonly an IgA protein. There are much less common ones as well, such as IgD. About 20% of patients don't have an M spike, but have other markers like an elevated serum free light chain level, either kappa or lambda, or elevations of light chains in the urine, which can be used to measure their disease. Light chains are actually fragments of antibodies. So all of these proteins are produced by the cancerous plasma cells. Regardless of what the marker is, we track it over time as we're treating patients. At the end, after each cycle of therapy, we measure the marker and see if it's gone down in response to treatment. And we assess the degree of response by how much we're able to lower those markers and ultimately lower the plasma cells in the bone marrow.
The tests that are used to follow the myeloma protein include a serum protein electrophoresis, or SPEP, a urine protein electrophoresis, or UPEP, which is often done on a 24-hour urine collection, as well as a test called a serum free light chain assay. And that also is another blood test that can measure levels of abnormal proteins in the blood, either the kappa or lambda light chains. In addition, there are two other tests called the serum immunofixation and urine immunofixation that also can be used, particularly when patients are getting into very deep responses and it's difficult to measure by the SPEP and UPEP. The immunofixations can often tell you if the patient still has a very low level of M protein left, or if they actually may be in a complete remission, meaning we can't measure it on any of those tests that I mentioned, and their bone marrow is now negative as well.
But more recently, it's been recognized, probably in the last maybe 30 or so years, that about 20% of people with myeloma actually have what is called light chain myeloma. And that means that they really don't usually have a spike or an M spike that can be determined by an SPEP. They will actually have an elevation in one of two types of light chains, either kappa or lambda. Now that used to be somewhat difficult to measure. About 20 years ago, a test was developed to actually specifically measure light chains in serum, and this is called a free light chain assay, and that's really helped us better identify that 20% of people who don't make a monoclonal protein. And then finally, there's about 1%, maybe a little bit less than 1% of people with myeloma that don't make any protein at all. So those patients, those serum tests may either not be very informative, or the abnormalities may be very minimal. So they can be a little bit more challenging to diagnose.